Sudden cuts to international funding have dealt a severe blow to the global fight against HIV and AIDS. The UN warns that millions of people will die and millions more will contract the disease if urgent action isn't taken. So, how can countries prevent a disaster? This is Inside Story. Hello, welcome to the programme. I'm Adrian Finighan. The United Nations AIDS Agency is warning that severe international funding cuts could lead to an additional 4 million AIDS-related deaths by 2029. The US was the single biggest donor to the global response to HIV and AIDS before the Trump administration abruptly halted foreign development assistance in January. UNAIDS says the withdrawal of assistance will have catastrophic consequences for the fight against the pandemic. So, what can countries do to reduce the impact of the funding cuts, and why did wealthy nations end their support for AIDS prevention and treatment programs? We'll discuss all that with our guests in just a moment, but first a report from Narges Mobilecki.
The HIV pandemic claims one life every minute, and now the UN is warning that number is set to rise. A new report says decades of progress in the fight against HIV and AIDS are in danger of unravelling after the Trump administration cut foreign assistance in January. UNAIDS says this has not just left a funding gap, it's created a ticking time bomb that puts the entire global HIV response in peril.
If the world does not act to mitigate and really ensure that there is continuity of support and resources for HIV prevention and treatment efforts, an additional 6 million HIV infections and an additional 4 million AIDS deaths will occur by 2029.
Those figures, the UN says, will take the world back to the late 1990s, the peak of the HIV pandemic. The report highlights the impact that the sudden, large-scale funding cuts from international donors are having on countries most affected by HIV, like the small southern African country of Eswatini. 1 in 4 adults here is HIV positive. It had been making significant progress in the fight against the disease. Infections had dropped by more than 70% since 2010, and death rates halved. The US used to fund up to 50% of its HIV programs, but not anymore.
We are running around to say, how can we ensure that those who are in treatment, first, they must remain on treatment. Make sure that we don't disrupt the services, even if we don't have the budget as I speak, but we need to look for money.
Nompilo was born with HIV. She relied on the mobile clinic and health outreach programs in her village, now halted.
Just having a mobile clinic come nearby your home just to make your refills for PrEP and ART, and also get free condoms. You see, those things really helped Emaswati a lot.
PEPFAR, the US President's emergency plan for AIDS relief, was the single largest contributor to the global HIV/AIDS response. The decision to cut funding was made with little warning.
It is cruel. You do not take away life-saving support from people just like that. You make a plan. You have a smooth transition. You give governments an opportunity to raise the resources they need to fill in the space.
But that space has not been filled, putting millions of lives at risk. Narges Mobilecki, Al Jazeera for Inside Story.
Let's bring in our guests. From Johannesburg, we're joined by Dr. Helen Rees, Director of the Reproductive Health and HIV Institute at the University of Witwatersrand. From Raleigh, North Carolina, we're joined by Dr. Krishna Udayakumar, Founding Director of the Duke Global Health Innovation Center, and from Washington, D.C., we have Nidhi Buri, a former Deputy Assistant Administrator for Global Health at USAID. A warm welcome to you all. Helen, let's start with you. The UNAIDS report for 2025 makes pretty alarming reading. It predicts 4 million more AIDS-related deaths, 6 million more infections by 2025. Is that a worst-case scenario? Can those numbers be averted?
Yes, they can. While it does make alarming reading now because of the sudden withdrawal of funds, we should just remember that we've made absolutely incredible strides. As a doctor, I remember the days before we had antiretrovirals in South Africa, where our hospitals were just full of young people dying and children and babies dying from HIV. And we've really reversed that, including things like mother-to-child transmission. So real strides have been made. I think, as was said in the brief film now, the difficulty has been the suddenness of this withdrawal that has not allowed countries to then think about what they can do to replace the funding. No one is anticipating being able to replace the funding in its entirety. The PEPFAR grants were extremely generous and saved millions of lives. But we are going to have to find both country resources and alternative, innovative ways to raise funds to support not only the HIV program, but many of the other challenges that we have, for example, in the African regions, so that we continue with things like vaccine delivery.
Krishna, as Helen said, real strides have been made, but is there a danger that we could return to the bad old days of the early 1990s, that the peak of the HIV and AIDS epidemic? Could the cut in funds trigger something like that?
I think we could see some short-term disruptions without a doubt, but I'm optimistic in that the tremendous progress we've made, the types of biomedical innovations we now have access to are so much better than what we were dealing with decades ago that I don't think we're going to backtrack to those days by any means. That's not to say that we should keep our heads in the sand and not worry about some of the short-term issues that we're starting to see. And exactly as we've already heard, it's really the suddenness of a transition that I think caught a lot of organizations off guard. We should recognize that while those tremendous progress metrics have been made, the global HIV and AIDS response was off track in terms of its own goals much before anything happened in terms of a particular funding cut in the last few months. So we do need to rethink what the future of this program is, which is not going to be to return to the status quo of a year or two ago, but really is the moment to reimagine what a next generation of response looks like, and in many ways that integrates HIV and AIDS programming into much stronger health systems that every country can lead to and be responsible for.
We'll talk about more about that in a few moments, Krishna. But first, Nidhi, with US aid cuts creating a vacuum, how might other nations, China, the EU, Gulf states, for example, step in? Is the issue of health being politicized?
Thanks for the question. So first of all, it's not just HIV, as you note. It's all areas of health right now are seeing decreased funding. And while the U.S. government's withdrawal and stepping back from the international space was certainly the most staggering given the abrupt nature, but also the scale of funding, we have seen other governments also make decisions to shift away from bilateral development assistance and perhaps redirect that to defense spending. We've seen that with the United Kingdom and when some partners in the EU. We, at the same time, are already seeing governments like Russia and China make promises to countries to fill the void from USAID. The overarching question is, what will investments look like, and will they actually be designed in partnership with governments in a way that support country ownership of these programs and their leadership going forward, and done in a way that actually sustainably improves health outcomes and accelerates those efforts? I do think to some degree, yes, we are seeing some government donors politicize health assistance, using it as a transactional tool, using this moment as an opportunity to address other geopolitical interests, as opposed to focusing on a targeted, accelerated effort to achieve certain health outcomes, and really understanding that the importance of achieving health outcomes, not just to reduce illness and to reduce mortality, but ultimately that saves, those investments save expenditures to health systems and to countries.
Helen, picking up on what Nidhi was saying there, many of the most affected countries are now beginning to step up, with many of them signalling plans to increase their HIV budgets. But many of these countries are, of course, poor and indebted. How can they afford to increase funding? What should the global community be doing right now to help them rather than throwing money at them?
Well, I think that it's not just the global community, but I think countries themselves are also looking inwards and saying, what can we do? I mean, a couple of the things just to suggest that countries are thinking about are things like taxes on the sin taxes, things on sugar and alcohol and tobacco. So can they change? Can we have new taxation? And for some countries, can you contact the diaspora? So it's not only looking at their own coffers from current taxation, but also innovation. But globally, I think apart from the traditional way of going to a funder and saying, can we have some money, please, as a funder? That's the sort of traditional approach that we've had. Now we're thinking much more about innovation. We're thinking about the private sector. We're thinking about innovative bonds. But we're also, for these very poor countries, and this has to be a dialogue we must think about debt, because many of these countries are spending the little bit of money they have on just repaying debt and debt interest. So can we do something constructive with debt where we allow poorest countries to rechannel that debt into their health services? So I think innovation is called for. There's a lot of thinking going on. And if you just reflect a bit on the African Union after COVID, all the leaders of the African Union countries have actually put their hands up and said, hang on, we don't want to be dependent anymore on manufactured products outside this region. We want to start manufacturing ourselves. So it is forcing people to think with innovation, not only about finances, but also just how do we sustain health services and how do we ensure access to products.
Krishna, do you agree with that? To what extent is the current reliance, the system that we have at the moment, the reliance upon donations, outmoded and in need of a complete overhaul? What might work better in the future?
I think Helen is exactly right. We have to reimagine and not try to go back to a prior model. And some of that is going to require innovation in the ways that we're delivering care, in the way that the public and private sector can work together effectively, in the types of next generation biomedical innovations that we can access to address pressing and emerging health challenges. We certainly have to deal with the debt crisis, but it looks very different than the prior debt crisis we might have seen a couple of decades ago, in that we're looking at China as the holder of most of the bilateral debt in African nations. We're looking at a lot of private sector debt that's been issued. So it's not going to be quite so straightforward to sit down with high income countries and resolve that. So thinking about things like health for debt swaps and other mechanisms that we can put in place where countries can channel tax revenue and payments out to health systems is going to be really important. And I do think another part of this has to be a transition from a 20-year plus approach to looking at diseases and looking at vertical programs has to shift to really thinking about how do we care for the health of populations and countries. And so we're not investing just in an HIV program, we're investing in primary health care. So we can look at issues certainly inclusive of HIV and AIDS, but also TB and malaria, as well as diabetes and obesity and heart disease. We know that there's a massive burden of non-communicable diseases that's actually killing more people in low and middle income countries than anything else right now. So we can't go back to a model where we try to preserve a single program focused on a single disease, but recognize that new systems have to be both more effective in dealing with multiple health conditions, but also much more efficient than anything we've done in the last generation.
Nidhi, do you agree with that? You were saying earlier, of course, it's not just HIV programs that are being impacted here. And as Krishna was saying, that there are opportunities here to address health needs and perhaps other approaches should be considered. How will the gaps be filled?
So I completely agree with the comments that have been shared. First, I'll just say, of course, there have been tremendous strides in the fight against a range of diseases, HIV, malaria, tuberculosis. But I will also say that the model that has been used for decades is not necessarily a model that is fit for purpose for health needs of the future. And I'll just speak to USAID, which I was very proud to serve at, which led, of course, significant efforts from the U.S. government. USAID's budget and health health was so heavily earmarked by the US Congress by specific disease areas, where on one side, the benefit was that allowed for a very targeted and sustained funding focus in achieving certain outcomes. But on the other side, it did not allow for the flexibility needed to really support foundational aspects of health in partner nations. And specifically, there was not an earmark to allow us to invest in health systems, in primary health care, to look at new and emerging health needs, such as non-communicable diseases that many partner nations pointed to. So I do think that this moment, as much as there has been a very irresponsible way of disrupting existing health programs, it needs to be embraced as a forced reset moment to really rethink how health investments are done going forward. And specifically, what we need to look at is how to work hand in glove with governments in investments in disease surveillance systems, in data collection and analysis, in lab capacity, in training of health workers, all of which are used, whether it's to look at specific diseases such as HIV or to look at new threats that may come up. And I'll give you one example. I've spent a lot of my career looking at emerging health threats, pandemic threats. In 2020, when I was helping lead the COVID response for USAID, the global response, it was actually the investments in health systems that were done through some of these specific disease programs, malaria and HIV, that could immediately be leveraged to be used for COVID. But at the same time, what we saw was a bifurcation of delivering health services when you have a real ability to create infrastructure and services as a one-stop shop for populations that you're trying to support.
Helen, would you agree with that? I mean, how should policymakers and donors weigh up the consequences on the fight against other diseases we were talking about here, TB, malaria, measles?
Oh, absolutely have to. I mean, we cannot have vertical programs anymore. And there's a whole lot of searching going on in lots of global corners, saying, how do we restructure the global health infrastructure? Because vertical programs, and we have many of them, often don't talk to each other, and they're often trying to build health systems, but specifically for a particular disease. And that's not a sustainable model. As was said, on the one hand, we're looking at these cuts in funding. On the other hand, many countries in the world have just signed up to the pandemic treaty. Now, pandemics, as we know no borders. And one of the critical things we have to do if we're serious about addressing and avoiding new pandemics is to build sustainable health systems. And that's not only the primary care system, but it is the surveillance system and the laboratory system and the community system as well. And that is going to be absolutely critical in the future. We've also seen the funding cuts affecting things like polio. The world is trying to eradicate polio, and it's that close to doing it, but that's the hardest bit to do. But if you take away all the investment in surveillance, in laboratories, in community identification of cases, and in responses, then you're going to throw away the billions and billions of dollars that we've so far invested. It makes no economic sense at all. And lastly, I think for politicians, something that's often not understood is that investment in health is hugely advantageous for economic growth. The WHO thinks that for every $1 invested in healthcare, you get $4 back in your economy. And for many of these low-income countries, economic growth is going to be critical to pull them out of poverty. But if you have a poor population who are affected by many of these diseases, you're not going to achieve that aim.
Krishna, how successful was the HIV response before the cuts? Was it meeting its goals? Was the program working as intended? Or do you agree with what Nidhi said? Perhaps this is a positive, a forced reset.
Yeah, I think this is the right time for such a reset. None of us would have wanted it to happen with such speed and such disruption that's costing people's lives in the process. So everything we can do to protect vulnerable populations in the coming months and years is what we should focus on. And also consider that we should be, on one hand, very proud of 20 years of global HIV and AIDS response, tens of millions of lives saved millions of babies born without HIV that wouldn't be otherwise. And there are tremendous things that have been done. At the same time, our global HIV and AIDS response was off track, not on target to meet goals for 2025 or 2030, much before this funding challenge arose. And so it is absolutely the time to rethink how we're going to be able to think about the next generation of programs. Not in any way to say it was a poor investment. It was some of the best dollars invested in saving lives and improving health systems and saving a whole generation in the last 20 years. And we need to move to a model where we can develop programs that are fit for purpose for what we have today, the tools that we have, whether it's medicines or prevention strategies or service delivery models or digital health and artificial intelligence should be what we design for. So I'm optimistic in the long term that we can get to a new model that's going to be even better at solving challenges in HIV and AIDS as well as other competing health challenges.
Nidhi, I pick up on that. I mean, you started it there by pointing out that this cut to funding it might possibly be a good thing in the long run, that it's going to force innovation. To what extent is innovation the key word here, in that it's going to provide new, more efficient ways of preventing deadly diseases?
Yeah, I mean, a couple points. So one, I think in the current and near-term time, the key focus is how to balance what has been clearly a very irresponsible way of disrupting the health system to minimize deaths, to minimize illness, to protect the gains that have been made, while in parallel thinking of what this longer-term rethink could look like for a system. There have been very promising innovations in HIV. I mean, very recently, the development of lenacapavir was announced. Lenacapavir is a new drug that can, with 2 injections a year, drastically reduce the likeliness of contracting HIV. There have been very promising innovations in the pipeline to address a range of other diseases. The key, I think, is twofold. One is, how do we ensure getting those innovations to scale? So once they become available products, how do we ensure that there is a link to service delivery in allowing them to equitably and fairly access populations around the world? And secondly, how do we continue a focus that has already been underway of working with different parts of the world in supporting manufacturing capacity for such health products, so that there are also swifter ways to support regions in accessing those products when they become available. That's true for both ongoing fights for HIV and other diseases. It's also incredibly needed for when we have pandemic risk or epidemic risk diseases. And Mpox, I think, is a great example of that. I had a chance last year when I was working on the Mpox response to go to Burundi and see how some of these innovations were being leveraged. The US government and other governments rapidly accelerated efforts to approve Mpox vaccines and support the donations of those vaccines to prevent additional cases, while in parallel testing and treating and supporting the addressing of current cases. But you have to have that overall research and development infrastructure in place to do those types of things during emergencies. It's not that you can just develop a product overnight. It's a long process to ensure the scientific rigor, the safety, and the efficacy that is needed. And so what we need to ensure is that full pipeline from research and development all the way through delivery of products is robustly supported and protected, but that we're also doing it in a way that supports that capacity around the world.
Helen, as of December 2024, 7 sub-Saharan countries had achieved the 95-95-95 targets. That's 95% of people living with HIV knowing their status, 95% of those on treatment, and 95% of those who are on treatment being virally suppressed. As a doctor on the front line in the fight against HIV and AIDS, confident that successes like that can be maintained and indeed scaled up even further without continued international funding?
No, I'm not confident, particularly for our own region, but because the amount of funding that is required to really bolster health services and allow that to continue is significant. And as was said, we're on the verge of a real breakthrough in HIV prevention using this new drug, lenacapavir. But unless we can roll it out, and it's an expensive drug at the moment, unless we can roll it out and roll it out at scale, we're not going to be able to reduce new infections. I'm also worried that if we lose even 10% of those 95, even if you've achieved it, if you start to lose your patients in retention and care, what you then have are people who are once again immunocompromised. What that means is that for their own health, they are going to get some of the symptoms of AIDS eventually. They're much more vulnerable to things like TB. But one of the things that I don't think has been given enough thought, especially if we're thinking about pandemics, what we saw for people living with HIV during COVID and with Mpox is that if you are immunocompromised because of your HIV infection, you are much more vulnerable to these other infections. If we want to stop pandemics and outbreaks, we can't have large numbers, millions and millions of people living with HIV whose immune system is weakened. We have to actually act on that. What we definitely will need, supplementary funding, but the model of that funding has to now be, as we've said before, much more innovative. It has to come from countries, and I can tell you that every African leader I've heard speak on this matter, including in South Africa,
Krishna, just quickly, we've got about a minute left on the discussion. The executive director of UNAIDS warned that this isn't just a funding gap, it's a ticking time bomb. But she also said that there's still time to turn this crisis into an opportunity, which is what I think we've heard throughout this discussion. You're optimistic, is that right?
Absolutely. I think the solutions we have access to are really promising, continue to grow. And what we need to do is bring the public and private sector together to look at new types of solutions and really make sure that we are protecting the most vulnerable members of our population in the way that we put this in place. But I think if we really start to think about what the next generation of health systems look like, we can make tremendous progress where we are enabling both healthier populations as well as economic growth, which is what most countries are going to need to continue to bring people out of poverty at the end of the day.
All right. There we must end it. Many thanks indeed. Doctors Helen, Rees and Krishna Udayakumar and Nidhi Buri. And thank you for watching too. You can see the programme again at any time by going to the website. That's at aljazeera.com. For further discussion, join us at our Facebook page. You'll find that at facebook.com/AJ Inside Story. And of course, you can join the conversation on X. Our handle there at AJ Inside Story. From me, Adrian Finighan, and the team here in Doha. Thanks for watching. We'll see you again. Bye for now.
Make sure to subscribe to our channel to get the latest news from Al Jazeera.